62-year-old female. It was presented with asymptomatic abdominal lymphadenopathy. Had a scan with an 8mm node in 2017, then had a CT urogram for other reasons, which we'll see, and then was evaluated on April 11th. A PET scan and marrow were performed. She does have a significant past history of congenital pulmonary valve stenosis, both valvular and subvalvular pulmonary stenosis, and had a valvotomy and repair in 1962, has a small ASD, and has a right bundle. She has significant scoliosis and hyperlipidemia. The performance score is 0. The exam was otherwise unremarkable. Her laboratory studies weren't remarkable. And could we see the radiology, please?
Yes. So in 2017, this is a CT abdomen. I think she probably had diverticulitis at that time. You can see here in her left pelvis. That's probably what got her to get this scan. And then we see a 0.8 centimeter node in her central mesentery. Following up 2 years later, we can see that diverticulitis resolved, but then this node has gotten larger, just a bit over what we would call abnormal. There was some haziness in the mesentery and some other lymph nodes that were prominent in size, but that was the biggest one. And then on her FDG PET scan, you can see that there's actually just one dominant central mesenteric node that's FDG avid, 4.9 SUV max. And typically we like to get the FDG first and then biopsy, especially in an area like this where we have other lymph nodes that are prominent and the mesentery can shift around. We went ahead and biopsied this. This was actually before the PET scan. I think we got lucky and we're biopsying that one dominant node in this case. And I'll end it there.
I'm impressed. All right, so this is that biopsy of that mesenteric lymph node. So we got some pretty good cores considering the size of that lymph node. You can see at the tip here, you can get the sense that there is perhaps an abnormal follicle here and another little nodule there. And CD20 staining highlights these follicles, as you can see here. CD10, also positive, and you can see a lot of CD10 positive B cells in the interfollicular areas, which is abnormal. And BCL2 is positive in most of these follicles, which is also abnormal, and so the predominant cell population here was that of small centrocytes, and so this was a follicular lymphoma grade 1-2.
So the question is, in this woman, stage 1A without marrow involvement, normal beta 2, the AMC was 550, but the ratio was normal. And so what do we do? Just to frame this in the discussion that I had with her, we went over the absolute monocyte count data. If you're less than 570, that's a good prognostic factor. By prima PI, she's has a negative marrow, low beta 2 microglobulin, so you can see where that even plays out with the Flippy. They do very well, and she has very minimal disease. The prima data set was advanced stage disease to come up with this, and we were the validation data set. Then by PET scan, we just had this paper come out, which is really fascinating paper, but half the PETs are normal essentially in follicular lymphoma. And if you have greater or equal to 2 extranodal sites, spleen, bone, or soft tissue, they all predicted a failure to achieve an EFS 24, which is a bad prognostic factor. And then we reported back in 2013 that transformation at 5 years was highest in those who were observed and lowest in those who initially received rituximab monotherapy. And there's some international data that has validated that. In her cause of death, she essentially is at a very low risk of dying of this disease. And I won't go through that data. And so come back to open this up. I think the further and harder you think about a case like this, the more complicated it could potentially be. I think the reaction to me There's always been very minimal disease. In fact, we biopsied this before the PET because we weren't even sure that this was disease. In fact, it was called something. It was called retroperitoneal fibrosis type of picture. It was very confusing in the outside records and so forth. And so I'll open this up for discussion and thoughts. Maybe start with Middlesex and Sparrow.
I would observe this patient. I don't really see any reason to treat her by criteria to treat for treatment unless patient insists on getting something.
Middlesex, any thoughts?
I agree to observe.
I'll ask those behind me.
Is she eligible for the clinical trial? That would probably no. It's stage 2.
No, but the point is the patient needs a little bit more disease than this one has to get on the trial.
Yeah.
It's the sort of person where you would consider treating versus, this is somebody who has very modest disease. I guess the other comment just to make is you have 2 years of scan evidence to say that the change was very modest, So that's one thing. And I guess the final question I'll defer to my radiation colleagues here is could you consider with curative intent radiation, although I realize it's in the bowel and there's risks there, but quite seriously, this is a patient with limited disease that you've known has remained limited for more than 2 years. Would you benefit from radiating this patient with a plan to try and cure it?
It'd be easy to radiate. We actually had a meeting where we had a thought leader from the U.S. versus the thought leader from Canada debating a case exactly like this. And I think the Mayo approach would actually side with the Canadian opinion. So take that for what you will. But the thought leader in the U.S. was arguing to do whole abdomen radiation for these cases, which I think is perhaps a product of his time and his training and probably far overkill. The point is that we, whether we're treated with TBI or whole abdomen doses, we've treated patients in the abdomen with much higher doses than you actually need for follicular lymphoma, and they actually tolerate things really well. So for the kind of benchmark intern level knowledge, the bowel can tolerate 30 gray to 300 cc's without any risk for serious toxicity. We never would get near 30 gray for this patient. And the nice thing about having a lot of scans is you can actually see where the nodules have moved over time, if they have. And so we can get a sense of how far things move and how much we need to treat. But observation's reasonable. We're happy to see her, and attempt a curative approach too would be very reasonable.
In my discussion with her was about observation, and she was not comfortable with that. I think is a fair way to say that. But then any of us involved in these discussions, this discussion consumes probably more time than most discussions we have in lymphoma. Steve was involved in a randomized trial of early stage disease. And so how many, I guess we'll call a vote since we'll take 2 votes today. How many would favor observation? How many would favor treatment?
Well, what are we treating with?
Let's go with single agent rituximab now, because not, or RT, either one.
RT.
RT, okay. Then RT, okay.
The bottom line is there's 2 different directions. The one direction is we are trying to cure a patient with limited stage disease, and therefore we are asking our radiation colleagues for help. And that's the reason to do something. In contrast, we don't tend.
Your conference is scheduled to end in 2 minutes.
And you want to do as little damage as possible, and then I would talk to the patient pretty strongly about observation. But because there's probably a 20% shot at curing her, I think that's the reason to consider the radiation therapy.
And the dose?
24 is very reasonable.
24.
I would tell you too, so at least the radiation series historically would suggest that we aim somewhere around 35 to 40% perhaps cure. At least our data would say that. The more modern data in the era of PET is a little younger, but at 5 years compared to the other series, we're doing about twice as well. So it's about 70% of patients who had 75% EFS at 5 years.
Result of better staging, let's say.
Right. So yeah, it's a product of better staging that we're actually treating more limited stage disease.
And the field would be total abdominal
No,
involved?
no, that's if you sent them to Sloan Kettering, that's what they'd get. Here, we would
Yeah.
do a more involved site approach.
Okay, so the consensus is involved field radiation therapy. So we've changed that plan also.
I know there was a consensus. It struck me as a 50-50.
Well, all right, I'll say
This is observation, not the consensus.
So the 50-50 was observation versus radiation therapies, 50-50.
And I think it
All
comes
right,
down to
I'll
the
follow
patient
that.
if she wants to be aggressive versus not.
Yeah.
Cure versus.
All right, that's very fair.
And if you're going to give systemic, I'll definitely put her on the trial. I mean, it's rituximab again versus perhaps Zevalin. So if you're going to
I
systemic,
don't think she's eligible because
Doesn't
size
have
and
enough disease.
not enough disease.
Wait for her to be.
Yeah, that looked at that. We've been trying to get people on that.
Finish with the radiation, and you wouldn't have quite.